here next to, how's our video?
It's good.
Awesome. Can you see pretty well?
Yeah.
Oh, look at that. Oh, nice. Okay, so she's not gonna label or do any of that because I provided you guys that PowerPoint that has pretty specific, but just to kind of give you an idea of where she is on the body and angling and, you know, adjusting depth and gain and all of that. So the first image is prox aorta. If you scan midline just under, actually, will you see my pointers over there? My little laser pointer? Yeah, my weird little pin, but it's very helpful. Let's see if it works. Can you guys kind of see it? Okay, so Rosa is just under the xiphoid process on the body, and if you kind of think back to orientation, she's in a sagittal plane, so this is anterior, posterior, superior, and inferior, okay? So the objective is to get the aorta prox. So this is the heart, most superior. So we know we're proximal when we can see not only the heart beating superior, but this left lobe of the liver. And by definition, the prox aorta runs from the diaphragm, or as high as you can get close to the heart here, to the celiac trunk. So Rosa's kind of tilting or I like to say rocking the probe to the left and to the right a little bit. The aorta is not always just perfectly positioned vertical on the body. It might have a little bit of tilts on the top or body, a little bit of tortuosity. So go ahead and like rock the probe where you can only see part of it, the aorta. Yeah. So see how here she doesn't have it elongated, but you can see this branch, this first branch and the second branch. This is your celiac trunk and this is the SMA, okay? But if she tilts the probe, kind of rocks it, she's gonna try to elongate the tube to get as much of the tube as possible in the structure. So that's ideally what you want to do, is you want to try to get the aorta to be as long as possible in your field of view. And then the part that you're gonna measure, because this is the celiac, so from this point all the way here, this is your prox aorta. So take a little breath and hold it. So where you can see the borders, nice and crisp, and at its largest point, you're gonna do an AP measurement, okay? This celiac and the SMA, those anterior branches that you, hopefully you guys are remembering the anatomy from going over that lecture that you're gonna be tested on next week, right? The aorta. So the most superior branch is that celiac trunk that we're gonna see. So this is the first one, and then see the SMA here. So this is anterior, and this is posterior. So these are gonna help guide you to know where your prox aorta is. You might not always have them perfect, but once you see them, then you know that you can take that image of the proximal area. And all that Rosa is doing is kind of fine little micro movements with her probe to get the borders nice and crisp and to elongate it as much as possible. So before we move on, I want to show you one of the techniques about, because often, and I'm sure when Rosa scanned you, she had you take a deep breath, okay? So right now, Kimberly is just breathing normally. Think about your orientation, okay? Again, this superior part, inferior part, anterior and posterior. So when Kimberly takes a deep breath, Rosa's not moving her probe. Let's go back.
I'm not moving it? Okay.
Yeah.
Okay, I'm not moving it.
So take a deep breath and hold it. Freeze. Notice how this liver moved further down on the screen. Okay, Rosa didn't move her probe at all, but everything kind of moved on the screen. So often what happens is initially you guys don't like your patients to take breaths because you might kind of have what you're looking for, and then everything changes when they take a deep breath. So when you take a deep breath, what happens to your lungs? they expand, right? You take a deep breath, you hold it, they're full of air. What's gonna happen to the diaphragm? Is it gonna go up or is it gonna go down? It's gonna go down. When your lungs fill, it pushes down on your diaphragm. So anything inferior to the diaphragm is gonna move inferior, right? So remember how I said this is superior and this is inferior. So if those structures were here superior, when she took a breath and held it, everything pushed down further in your screen. You basically are manipulating your objective to go to a different part of your screen. And also taking a breath kind of takes the movement away, and it usually will sharpen your image very nice. It pushes the bowel gas if it's covering and can help improve the image quality. So that's something that I'll have you guys do, is play around with the deep breathing to see how your structures move. And so you can use it to your advantage and not be afraid of having your patients take a deep breath and hold it. One thing often I'll tell a patient is, I'm gonna be asking you to take a deep breath. If I forget to tell you to breathe, please breathe when you need to, right? Because you have different types of patients. You have very compliant patients who are gonna sit there and die on the table holding their breath because you forgot to tell them to breathe. Then you have the ones that you say, take a deep breath and hold it, and they go like that. So, you know, sometimes you forget to tell people to breathe. So it's a good thing to tell people, if I forget and you need to breathe, go ahead and breathe or something. Or hold your breath, hold it, okay, breathe. And work with your patients that way, because they'll be doing, for abdomen, you're gonna be doing a lot of breathing, okay? All right, so first image, there's one measurement. You saw she took an AP measurement. Notice how the aorta is kind of at an angle. Okay, so this is deeper. This is the prox. As we go more inferior, notice how it gets closer to the screen, or to the transducer. Remember, our transducer sound beam's here. So think about the anatomy. The prox part is deeper, posterior to the left lobe. As you go more inferior, the aorta becomes more superficial. So it gets closer to the skin. So that's why you see it at an angle, because this is superior and this is inferior, and it's starting to get more superficial the more inferior you go. You can manipulate the way that you see the aorta. See how Rosa's getting it more horizontal on the screen? And all she's doing is applying more pressure to that top part of the probe. So notice how this, instead of being at an angle here, it went closer to the sound beam, because she pushed on the top of the probe only, and it squished this tissue a little bit more and brought that structure up to be more horizontal. Now, heel the transducer, like apply. So now she's applying more pressure to the bottom of the probe, and see how much closer this part here is getting to that. So you'll hear me say often toe and heel, or heel toe the probe. So Rosa, put the probe up. Think of your probe like a foot. The top is the toe and the bottom is the heel. If you're toeing it, you're putting more pressure on the top. If you're heeling it, you're putting more pressure on the bottom, okay? So that's just angling and manipulating your objective to be more centered or horizontal, or especially when you guys do vascular and you need a more specific angle. Now, one caveat with that is when you have really thin patients, you need to, in order to get an image all the way here, that probe has to have contact on the skin. So if Rosa heals the probe and do loss of contact on the tops and show them. Like show them when you don't have contact on the skin. See right here? This just means that she doesn't have contact on the skin. So we call that loss of contact. Sometimes with really thin patients who don't have like tissue for that probe to kind of sink in, and nice, like, you know, belly to kind of let that probe have contact, and they're just bones, it's hard to get contact, and we can squirt some gel there and create a little barrier between the footprint and the skin if you're really, when you're struggling with keeping contact. This probe actually has a pretty large footprint, so when you start to move and go intercostal and deal with the ribs, you might struggle with a lot of loss of contact. So ideally you really want to keep that probe, and that requires you to put pressure, a decent amount of pressure on the skin. So it's a hard balance between pressing too hard or pressing enough, right? Typically you guys starting off are scared to press because you don't want to hurt your patients. So apply less pressure. I mean, she's so easy, it might not show.
I know.
This
is like
so she's barely touching. Now apply pressure. See how everything crispens up? So it does make a difference in the image quality there. Okay, so for the first image, we're starting at the aorta. This sequence of images is very logical. We're going from the left side of the body in a sagittal plane, and we're sweeping basically from the left side to the right side and scooting all the way to the right in a sagittal plane. And then we go transverse, we go back midline, and we angle all the way up superior, and we're coming inferior. So as we're going through this protocol, it's basically going from the left side of the body to the right side of the body in two different planes. So from the aorta, we're going to start to rock towards the right side of the body. And when I say rock the probe or move the probe, I want you to think of the sound beam that's coming off of the end of the probe. You want it to go in that direction. So when she rocks towards the right, her probe's going to the left, but the sound beam's going to the right. Okay, so often I'm gonna say rock to the right or left, and I'm talking about the anatomy I want you to pick up with the sound beam, okay? So the next image is the medial part of the left lobe and the caudate lobe. And a lot of this we haven't gone over yet, so I'm just gonna explain it to you, and then as you start to review it more, it starts to make more sense. So from the level of the aorta, okay, we're going to look at this posterior part of the left lobe, and the caudate lobe runs on the posterior part of the left lobe. So we're gonna see this little tongue-like projection that sticks out here between the left lobe and the right lobe, and that's called the caudate lobe. And there's this bright ligament that runs between the left lobe. This little thing is, you have to be at the right angle, is the ligament of venosum. So take a deep breath.
There you go.
Decrease your depth. And freeze. So this is just a little loss of contact here. This little echo start from here. So we've got the superior border of the left lobe. This is the posterior border of the left lobe, the inferior part, and the anterior part up at the top here. So this little, can you guys see my pointer? Or is faint? Okay. Here, this little projection, this is your caudate lobe, and this little echo that runs between, that's the ligament of venosum. So we look for that landmark. We want to have the left lobe of the liver and the caudate lobe for the second one. Now from the caudate lobe, we're going to continue to rock towards the right. Oh, look how pretty. See that ligament that runs through? It's really bright. And see this little structure below? This is the caudate lobe. I call it a tongue-like projection because in my mind, remember earlier, a few of you were talking about like a kind of like art, you know, when you look at an image and you go, oh, that looks like such. Well, when you're in real time and you rock back and forth, it looks like this. The tongue looks like the caudate lobe. And as you rock from right to left, it goes in and out of your image there. So ideally, you should have the caudate lobe between the aorta and the IVC. So aorta is here to the left, the IVC is on the right side of the body, the caudate lobe is between those two structures. Okay. So next we're gonna go from caudate to the IVC, and we'll still have the left lobe anterior, see the IVC here, and then posterior is a little bit of the right lobe. Okay, so we want left lobe, right lobe, and then elongated IVC. So since we're showing the difference between aorta and IVC, I'm gonna have Rosa kind of rock back and forth between the aorta and the IVC so you guys can differentiate its characteristics. This is almost like the first thing that you work on is finding aorta versus IVC. Often the IVC is the first one you find because it's a little bit larger. The liver surrounds it, so you have a better acoustic window, and sometimes the aorta can be, it's deeper, the prox, and it can be a little challenging. So here's IVC, there's aorta. What are some of the characteristics that are different about aorta than the IVC?
It's the IVC has like little margins and it's like straight.
Very good. So I like to describe that more that the walls of the aorta are more even and the aorta pulsates. So go to the aorta, see how it's pulsating. So it's evenly pulsating. You see the walls evenly as the heart beats, it's pulsating. Go to the IVC. Now, you might think this is pulsating, but we're so high close to the heart that it's kind of variable. Okay, so the IVC is more variable because it has valves. Okay, so notice how it doesn't evenly change shape. So with respiration, you see it variable and the wall is much, see how it kind of collapses? The IVC will collapse with respiration. That's why it looks so, like what Tony was saying, it looks a little, what was the word you used? Like rigid. The walls look more rigid. Well, they're more uneven because it's variable based on the respiration, where the where the aorta pulsates evenly and the walls look very bright and straight. Another thing is IVC, notice how it pierces here through the liver. You have liver posterior and liver anterior. Go back to the aorta. The aorta is completely posterior to the liver. It doesn't pierce through the liver, okay? And you might not notice because she's scanning, but she's pointed to the left side of the body. When you go to the IVC, you're pointed to the right side of the body, okay? So aorta is more left and IVC is more right. We call this phenomenon here hammocking. Notice how it looks like a hammock. It kind of comes up and tilts back up superior here. It's got like a curved shape. The liver or the IVC hammocks there in the superior part of the liver, versus aorta is nice and straight and posterior, completely posterior to the left lobe. And it has anterior branches that you can identify off of it. So that's one thing initially that you guys will be doing, is trying to differentiate aorta and IVC. All right, nice job, Miss Rosa. All right, so that's IVC. The fourth image is the gallbladder long axis. So she's gonna start to slide along the inferior costal margin and look for, the gallbladder is gonna be anechoic when it's full. Kimberly ate, but you can, we can still see her gallbladder here. It might not be completely full, but we can still identify its borders. So here is kind of like a teardrop shape. Miss Rosa is scanning on the inferior costal margin.
You want me here?
Yeah,
Okay.
there's a few approaches. You can scan along the inferior costal margin, or you can go intercostal, which means she's in between the rib cages on the right side. So these black lines are just ribs. So there is the gallbladder intercostal. So we're a little closer to the sound beam there because we're right in between the liver versus, go back to subcostal. So on this one, you want to oblique your probe, turn your probe to elongate the gallbladder as long as possible. So the gallbladder lie is variable. It doesn't lie straight up and down on the body. It can lie anterior, posterior, front to back. It can lie side to side. It has very variable. You could be in a transverse plane getting its long axis. So you have to eliminate the being long on the body and transverse. You have to think to its long axis. So that's where the rotation of the probe comes into play. This is the neck of the gallbladder that's most superior, and the fundus of the gallbladder is most inferior. Okay, so ideally you want to try to get it as long as possible, showing the neck, body, and fundus of the gallbladder. And we can even, we're at 12 centimeters, so we can decrease our depth to kind of do one more there, one more. We can fill up our whole space with the long axis of the gallbladder. So that's what the gallbladder long axis will look like. All right, now we're gonna keep moving along the right costal margin, and we're gonna go down to the inferior part. We're gonna demonstrate the right lobe of the liver and the right kidney. And we call this the kidney-liver interface. This objective has a few things that you're looking at. So first one is you want to show the as much right lobe, kind of half of your image should be liver and half kidney. You might not get the long axis there. So there we go.
That's good.
Yeah.
Very normal.
So we're going to show in this image, the objective is to compare the echogenicity of the kidney to the right lobe of the liver, and that helps us determine, you know, if the tweak the top part of the probe back towards the back a little bit, like go the opposite way. Yeah, a little bit more.
And I'm losing the mark. I'm very normal.
I want to see a little bit more of that right lobe. Yeah.
Take the breath.
There you go. Yeah. Beautiful. So we want to get the right lobe all the way to the diaphragm. That's this bright structure here. So that we're going to adjust our depth till we see that. And then this is the superior part of the right lobe. And what is this space called between the right lobe and the kidney?
Morson's pouch.
That's Morson's pouch. So Kimberly doesn't have any fluid. So notice how they abut right up next to each other. If she had ascites, this is where you're gonna see anechoic fluid here in this space in Morson's pouch. It's the most dependent part of the peritoneal cavity of that abdomen. The fluid will go there first, okay? So we're looking for fluid, and we're looking for a crisp interface to compare the echogenicity, so we know whether the liver's fatty or if the kidney's echogenic. A normal kidney and liver, the kidney is slightly hypoechoic, the cortex, to liver echogenicity, or sometimes isoechoic. That's normal too. Okay, so that's kidney-liver interface. And then we're going to now just focus on the right kidney and make that our center of focus to get it as long as possible, so you can take a measurement of the long axis of the right kidney. So Rose is just obliquing the probe, coming a little more inferior to get that inferior part. And beautiful. So we want to try to get it as horizontal as possible and not like a rocket straight up and down. Okay. And what Rose is showing here, you want to show them rocket kidneys?
Yes.
They call them student rocket kidneys.
Like that.
See how it's more straight up and down? And the first one she had is more horizontal.
Take the breath.
So the more lateral you go on the body, the more you're almost really coronal getting the best long axis. So if we take this kidney here and we kind of split the center, this is the superior, this is the inferior, and she's gonna take a measurement from superior to inferior and then perpendicular to that.
Where are you center? Oh. No?
I just hit it again, the measure one more time, there you go. So you've got two measurements there that you'll take on this image. There is an option, go ahead and hit that option and show them, show caliper lines. This one right there. There is an option in your measurements that can show like the lines and not just the calipers. to make sure that your measurements are actually perpendicular to one another and you're not getting like an obtuse measurement. You want it to be an acute angle when you're taking two measurements. Beautiful.
Thank you.
All right, so those are all the sagittal. Now we're gonna move to transverse, and she's gonna go back up to the xiphoid, just under the xiphoid process. Now we're gonna take an image of the liver, of the right and left lobe, because our sound beam's going from right to left. Okay, so we're gonna see some of right, some of left at the level of the hepatic veins. So the hepatic veins are most superior. They dump into the IVC on the most superior aspect. So your probe is gonna be angled up superior, and you're gonna look here, here's the heart over on the left side, here's IVC, and then the hepatic veins kind of branch off. We call this either the moose sign or the Playboy bunny sign, because the veins look like either a moose head or a Playboy bunny, okay? And as we go through the anatomy, go a little more, take a deep breath. Yeah, can you get a little bit of the right, or is that one?
Last one is like a
That's
bunny
probably
sign.
right there, yeah.
Yeah,
There's bunny
okay.
sign. You guys see why we say the like Playboy bunny sign, right? So all this is showing is the left. Remember, this is the left side of the body, this is right. So we have left hepatic, here's the middle hepatic. We can't quite see the right because she's focused more on the left side. So you'll find that these structures are gonna help differentiate the segments of the liver when we get into the liver a little deeper. So we've got left lateral, left medial, anterior right, and we can't see the right. She'll show you what it looks like with the moose head. I think that first one kind of
Take a
showed
deep
us.
breath.
See, coming in right here. That's your right hepatic. Okay, all of these are dumping into this IVC here. So these are our landmarks. Ideally, the focus is the liver at the level of those structures. So we're gonna try to make the liver nice and clear as possible to demonstrate. You might not get all of the hepatics at the same time. Go back. Yeah, just make the liver look the best right there, Freeze. Beautiful. So see how much more clear? We're gonna use this diaphragm as a reference to know how deep we need to be. If we can see the diaphragm, we have enough depth. If we've got a little bit more than we need, we can always adjust our depth to bring it a little bit closer and decrease the depth, okay? So I'm gonna have her show you what it looks like if you're too shallow and you're cutting off the liver.
Take a deep breath.
So notice how it's much closer, but I can't see that diaphragm here. I wanna be able to see that diaphragm. So I would comment, I would say increase the depth, and she just increased the depth some, and now you can actually demonstrate that diaphragm. So your diaphragm is one of your biggest landmarks when you're scanning the liver to help you know, do I have all the liver, do I not? Okay. So that's your first transverse image. There's no measurements. Next one is aorta mid. So from that same window, just under the xiphoid process, we're going to examine the aorta in a transverse view. In a long view, it looks like a tube. So when I slice this tube axial, it's gonna look like a circle. And what we're looking for in this mid aorta is think about all the anterior branches of the aorta and the lateral branches. You have your celiac trunk, you have your SMA, then laterally your renal arteries come off. So we're going to scan, I use the spine, okay, so see this echogenic kind of looks like a frown there on the bottom of the screen. This is the spine, and the aorta runs just anterior and to the left of the spine. So if you're trying to figure out which black circle is the aorta, think about your Legos and the building blocks. And now we're just coming from the bottom. So if I can see the spine, I know the aorta is right above it. This is my aorta because it's to the left. This is my IVC because it's to the right. We can see them both at the same time. So then I'm gonna hyper focus on this tubular structure, and I'm gonna sweep through it from superior to inferior. So she goes more superior, most superior, right there. This is, I'm gonna show you guys, have you talked about the Siegel sign? You guys remember hearing that in the lecture? So the Siegel sign is your celiac trunk. It's your hepatic artery and your splenic artery, and they look like wings coming off of it. So as she's scanning, notice, go back up right there. See right there? She's just got one wing. But this is her celiac trunk right there. There it is.
Kind of oblique.
It's a little oblique there.
Yeah,
See those
because I
two
cannot
little
see it.
structures?
Yeah, there was.
So that means that we're very superior. In order to know we're on the mid, we're gonna go slightly inferior, and we're gonna look for the SMA. See this little dot right here? So that when the SMA branches off the aorta, I know that I'm in the mid, and also I can use these renal arteries to decrease your depth, and then just take a picture with the renal arteries, the right and left, so that I can show them.
Take a small breath. Hold.
Beautiful. So this is like a textbook, okay? It's gonna look just like the textbook when you see this picture. So if we're thinking of your building blocks, your Legos, here's the left lobe of the liver, here's the pancreas, okay? Here's my confluence, here's my SMA, then this here, over here is my IVC, and then we're missing some of the connection, but this is the left renal vein that goes between the SMA and the aorta. So this structure here is my aorta, and I'm seeing these two little structures coming off each side. So because I know my orientation, and this side is right and this side is left, the one that's coming this way is going to be which renal artery? Right or left? Right. And then this one is going to be my left, because it's going towards the left side. Okay, so how to know that you're in the mid? You're going to use your SMA as a landmark. You should see that anterior, and also you'll start to see, you won't always have it perfect like this with your renal arteries, but you want to get it more round. Okay, so Rose is going to take a picture of the aorta looking a little more round at that level, so you can take a nice measurement.
Don't take it.
Beautiful. You might have them in there no matter. The only thing is that
You don't wanna
renal
get it out
vein.
there.
Yeah.
I could.
Push out. Have her push out on her belly. There.
Good.
There you go. So take a measurement. So on this, you're going to take an anterior and posterior and a right to left measurement. And typically, if you have it pretty round, they should be, look, 1.6, 1.6. They're almost perfect. You got it nice and round. Okay. So that's your mid aorta. Now we're gonna do the long axis of the pancreas. So using the same technique that we found the mid aorta is what I'm gonna have you guys use for the pancreas. So we're gonna use this left lobe of the liver as an acoustic window, and you're up really high on the just under the xiphoid process, and you're like angling posterior or inferior from that level. If you just move your probe up and down, the stomach is in front of the pancreas. So if you try to scan through the stomach, which is over here, okay, it's gonna cover over it. So think about you being the sound beam, and you're trying to move around the structures that are in your way. So you're gonna start up pretty high, that left lobe of the liver, and push an angle inferior. So you're trying to go behind the stomach to get this pancreas. Now the pancreas long axis is one of the organs that doesn't run longitudinal in the body, it runs transverse oblique. So if you look at her probe on the body,
It's like this.
the left side of the probe where the notch is inferior, that's equivalent to the head, and the tail is up towards her left shoulder, because the pancreas runs like this in the body. Its head is inferior, tail is superior, and actually towards the back, but it's superior and posterior. Okay, so if I have my probe just transverse, I'm not gonna be able to catch the tail. You're just only gonna see the body. So in order to get its long axis, I'm gonna be transverse oblique in order to see that tail. And that's what we're seeing here coming down. Here's my splenic vein that runs posterior. So my head, you know, I can see my IVC, I can see my aorta, and here is the pancreas head, then the body, and then the tail comes all the way down here. Now, if she just goes transverse, I lost majority of my head and majority of my tail because she's just scanning the body. She has to be at that oblique plane in order to find the pancreas. Now, her pancreas and her liver are pretty isoechoic. So they're kind of blending at the top here. So I like to find a little echo, a little line here of the liver and follow it along the border to kind of see where the anterior border of the pancreas is, because they're pretty isoechoic. Some of you will find that maybe your pancreas is more hyperechoic. The older we get, fat, it's not encapsulated, so fat can infiltrate the pancreas pretty easy. Or if you have, you know, fat that's infiltrated, even if you're not older, it might be brighter. And then you really see a differentiation between the liver and the pancreas echogenicity. All right, so that's the long axis. And we just use, as far as depth, we're gonna use that tail of the pancreas, because that's the deepest part, as a reference if I need more depth or less depth. Next is transverse gallbladder, and I just have one picture of the body that you're gonna do. These are just like a few pictures of full protocols. It's just to help you guys find the structure and be able to identify it. So when we go back towards the right side of the body, and we had a long axis, you start to rotate the probe counterclockwise. And when you see the gallbladder look like a circle, then you're rocking superior and inferior to find its neck, body, and fundus. So the neck is most superior. Notice how you see the most amount of liver, and it's the smallest part. Body is a little bit less liver, and fundus is most inferior. So we see the least amount of liver. So the body will be in between the neck and the fundus. And all that is just either you're angling the probe or you're moving the probe superior and inferior. So on this one, many of you, we've talked about today when we were looking at knobology about the size of the sector. So notice how wide our sector field of view is, and our objective's pretty small here. So this is a good example where you can actually decrease your sector size some. And look how pretty that looks. See how much that improved? It increased your lines per frame. It made a really nice window, and because it's not a long structure, we can get rid of the side parts of it. Okay, so that would be your gallbladder body. Next is the right lobe of the liver with the right portal vein. So Rosa opened up the field of view back to its widest point, because we're going to try to get as much of the right lobe of the liver and the right portal vein, which will kind of traverse the liver when you're on the right portal vein. Okay, so the portal system, you have main portal, right portal, and left portal. And it's all continuous with each other, but it's very hard to demonstrate all of them at one time because they course differently in the body as they branch off. So on this image, the right portal, when you're in transverse, you're gonna see its longest view. So I say it traverses, which means that it goes right through the right lobe, and it's gonna be at its longest point. This is just loss of contact there. See if you try to come subcostal and no, on the subcostal and really angle to the right, push on her belly, and see what that looks like instead of intercostal first. Let's see. Take a deep breath. push on that left side of the probe a little bit, right there. There you go. So this view, Rose is coming more subcostal, okay, so which means like underneath the ribs. The first view she showed you, she was kind of intercostal, and notice how the portal looks a little bit more horizontal here because she's subcostal. This is just loss of contact because the probe is large and she's very thin. It's hard to get the border of the liver, but look, she improved that. So ideally we want to see all of this right side all the way to the diaphragm, and then the right portal will traverse through. What do you guys notice about the walls of the portal versus what we saw with the hepatic veins?
They're hyperechoic.
Yeah, see how hyperechoic? See how thick they are? And hyperechoic? Okay.
So the portal veins are the ones up higher, the more superior. Are those the first ones? Or the portal veins are the ones that come off of the proper, no, I'm getting it confused.
So remember the portal system is a
portal.
completely separate system than the IVC and the aorta, okay?
Oh, okay.
So your portal system has your right portal, your main portal, left portal, and that is what anybody know what forms the portal vein?
Is that your splenic vein and your SMV?
Exactly. So the splenic vein and the SMV, which is what we saw when we were at the pancreas, those merge and form your portal vein. And that's your main blood supply to the liver, is the portal system. So the portal system and its branches are completely separate great vessel system from the IVC and the aorta. Don't confuse the branches of those systems with the portal vein. Often that happens, many people will think because it's a vein that it's, it dumps into the IVC, but it's its own separate system.
It doesn't ever connect. I mean, I know eventually it would, but like in the abdomen, it never connects to the IVC?
No.
No.
No, it's its own structure, its own system, basically. Okay, and it has very bright, thick walls. And the venous system with the IVC, like we saw with the hepatic veins, very thin walls. Okay, so that's, and when we go through all the anatomy, especially in the liver, and you guys might be doing portal system too with Miss E right now. I don't know. Did you guys start great vessels or anything yet? Okay. We'll get more in detail of those branches and stuff. But the thick walls and horizontal and the right lobe of the liver, that's what we're looking for there. And then lastly, we're going to go back to the right costal margin. Now we're going to look at the right kidney in a transverse view. So we're going to slice it axial, and we're going to look at the mid part of it. So when we sweep through a kidney, we go all the way superior, all the way inferior. But the image that I want you to take is at the midpoint. When we know we're mid on the kidney and transverse, it looks like a C. So see here, here's our C. And the C has like the opening here, that's the hilum, where the arteries and veins enter and exit the kidney. So, beautiful. So we can see this C-like shape. Now, we see it pretty horizontal, but you might see the C at different angles, kind of like this, with the opening down versus the opening to the side. All that means is you changed your approach on the patient. So if she comes more lateral, the hilum, the opening of that C might go down, because she's coming from a lateral approach. If she's more anterior, see how it's kind of crooked now? But it still has this C shape, and here's my opening, because she moved more lateral on the body. But ideally, no matter what approach you take, I call the C, I call them like chompers, like Pac-Man. Do you guys know Pac-Man? So these little cortex, the chompers, we want them to be even. We don't want one to be like this or one to look like this. That means that you're not axial. When these chompers are even, whether it's horizontal or at different angles, you're truly getting an axial view. Okay, and we can see this little hilum opening here. So then we're going to take a measurement from the hilum to the lateral part and then perpendicular to that.
Is this hilum different than, isn't there one on the liver, or is this the same? Is there a hilum on the liver?
Well, there's a hilum where the vessels
Okay.
enter and exit as well, but the renal hilum is different than
Okay.
anything with the liver. So the hilum, just think of what that word means. It's kind of like an enter and exit area of a structure. So you have a hilum in the kidney where the arteries and the vein enter and exit there too. So go oblique on it so we can show them if it's not truly axial. Yeah, like that. So notice how, remember how I did my fingers like this? So the top chomper is longer than the bottom. So in order to make them even, she's just gonna rotate her probe more to get the C shape. See that there? Now, Rosa, go all the way inferior on the kidney, so you can show them how it's like a circle. So when you're inferior, it looks like a donut, like all circle. Go all the way superior. Take a deep breath. So see how it's completely circular? That's superior. Now she's gonna keep going. Now here's the opening with the C, that's mid. So when we do a full kidney protocol, you'll go all the way superior, mid, then inferior, and it helps you identify, like, you know, if there's any abnormality. You're just taking representative images. Right now, I'm just having you take one on the mid, but it's important that you can kind of rock through the whole structure so you know which part the mid is. Okay? And then there are 2 measurements that you take for that.
Okay.
Do you guys have any questions? Are you excited or nervous? They all seem like, oh my cow.
This is so interesting.
Once you start scanning, you guys are going to be so excited, and